Welcome, everyone. My name is Joanna Cohn. I'm director of the Institute for Global Tobacco Control at the Johns Hopkins Bloomberg School of Public Health. And I am delighted to welcome our Innovations in Tobacco Control speaker today, Dr. Kamran Siddiqi. Dr. Siddiqi is professor in global public health in the Department of Health Sciences at the University of York. And he's also associate dean with an international portfolio at Hull York Medical School in York in the UK. He is a double doctor. He has his MBBS and MRCP and a PhD. He's covered across the board. And his background is in chest medicine, public health, and epidemiology. In addition, he holds an honorary consultant post in public health medicine at Public Health England. He's also the director of a global health research center that's focused on preventing non-communicable diseases called IMPACT, and that's funded by the UK National Institute on Health and Care Research. And he's served on several national funding boards and national international guideline development committees. He has published extensively and received a super high number of grants related to TB, tobacco control, and tobacco cessation. And he's also demonstrated commitment both in terms of receiving grants to do the work and in publishing on research capacity building focused in low and middle income countries, as well as specifically in the area of smokeless tobacco, which is an area, that needs a lot, that has been sort of neglected compared to the number of users and people who suffer from death and disease from smokeless tobacco. So I'm really thrilled that he's going to combine all of these interests and focus his lecture today on policies related to smokeless tobacco in low and middle income countries. So Dr. Siddiqi, welcome. Thanks so much for being here.
Thank you very much, Joanna, for a very generous introduction. So let me just share my screen. All right. Well, I'm really, really excited to be here. And I want to start by actually thanking those who've joined today, and also to the Institute for Global Tobacco Control for inviting me. I'm also very grateful to a number of colleagues here and a number of partners who I've worked together and had the privilege of working together with across South Asia and also in the UK and other countries. And you can see their logos at the bottom. We came together about 4 years ago to form a research group called ASTRA. And ASTRA stands for Addressing Smokeless Tobacco Use and Building Research Capacity in South Asia. We were very lucky to get funded from the National Institute of Health Research, which is a government body that funds health research, including global health research. And I was just very blessed to actually have the support for so many partners. I would just like to mention a couple. The first and foremost is the WHO FCTC Secretariat that have been very supportive to us throughout. And then the Knowledge Hub that they created within the National Institute for Cancer Prevention Research in India. And this is a knowledge hub on smokeless tobacco. And in fact, today they have launched a new publication called Implementation Practices in Smokeless Tobacco Control. And I would like you to have a read of this. I will leave a link at the end of my slideshow. So hopefully you'll be able to look at that. So yeah, I mean, I put a few slides together. And by the way, this is our group. We actually took this picture at an annual meeting of ASTRA, and you can see all the bright people who worked together and supported this work. So I'll be presenting today on behalf of all of them, and I think I'm just a small part of a big research machine, if you like to call it, but a family, but just I'm very grateful to their help over the last 4 years. So the slides will speak about why does smokeless tobacco need special attention. And I think that's where I'm going to sort of spend first few minutes. And then I'll be talking about some of the policy gaps. And this speaks directly to some of the work that we've done within Astra. And then towards the end, I'd like to provide or present some recommendations of how we address these gaps. So let's begin with just trying to understand what is smokeless tobacco. I mean, you can see at the bottom left-hand corner, there is a definition. But I think the most important thing to remember about smokeless tobacco is not a single product. So it's not like a cigarette where you have got a single product. When you think of smokeless tobacco, a whole array of products come to mind. And they could be literally hundreds of products if you include all the kind of different brand names. And they're not different just in brands, they're different in a number of ways in terms of their composition, the way they're consumed, the way they're manufactured, processed, and so on. And that's quite important, as I would explain in a little bit. A quarter of world's tobacco is consumed in the form of smokeless tobacco. So we know we have about 1.2, 1.3 million people using tobacco, and a quarter of them, roughly around 350 million people, use smokeless tobacco. Most of them actually use smokeless tobacco on its own, but there are few who also use it together with smoking forms of tobacco. It is a global issue. We've so far reports from 140 countries using smokeless tobacco. But most of them live in South Asia and Southeast Asia. So they're probably 85% of all of smokeless tobacco users live there. And that's roughly 300 million people. Unfortunately, the products that are available in Southeast Asia are the most lethal and most unregulated products. And again, a lot of my talk is about their potential for causing harm, and also in terms of how unregulated they are. But just before I go and focus on Southeast Asia, it's a reminder that it is a global health problem. And here we have a chart indicating a world map with prevalence of smokeless tobacco. And I'm just focusing on smokeless tobacco among females. And the darker the shadow is, the higher the prevalence. And while you can see that most of the prevalent countries are in Southeast Asia, but there are several countries in East, Southern, Western Africa that have also got very high prevalence of smokeless tobacco, and of course Nordic countries. And I'll speak a little bit about the Swedish snus as well. But most of my talk, as the title indicates, is focused on low and middle income countries, in particular those in Southeast Asian region. So going to Southeast Asian region, here I've got a bar chart, and you've got these groups where different Southeast Asian countries are grouped together, indicating the prevalence of smokeless tobacco use. And it's also disaggregated in terms of men and women. And I think the thing to note here is, in particular, is there are certain countries with very high prevalence of smokeless tobacco. So Myanmar, I think, tops the chart with very high prevalence. So among males, 62% of males are consuming smokeless tobacco. And that is quite alarming. But I think what probably should mention is that India, being the biggest country in the whole region, and although their prevalence is about 30% in males and about 13% in females, but in terms of total numbers, India has probably got the highest, well, definitely got the highest number of smokeless tobacco users in the world, not just in the region. The other thing to note here is the prevalence amongst women. And I think that is quite alarming. If you look at the Bangladesh figures, you can see that almost a quarter of all Bangladeshi adult women using smokeless tobacco. And again, the picture is very similar in Timor-Leste. This isn't the picture that we see when we look at the figures for cigarettes, for example. We know that the cigarette prevalence is roughly between 1 to 4% in low and middle income countries, but that is certainly not the case in case of smokeless tobacco, where smokeless tobacco is quite prevalent. And one of the reasons, and there are many reasons, but I think one of the reasons is that there's still quite a lot of stigma attached to smoking and smoking cigarettes among women, while smokeless tobacco use is culturally acceptable and socially acceptable, and therefore it's much more popular and much more common and visible amongst women. So let's look at some of the other disparities. So I've talked about the gender issue, but if you look at socioeconomic status, if you look at the rural-urban divide, then again we see the picture here is that the people who are least educated or have got least amount of material wealth, or they're living in rural areas, they're more likely to be using smokeless tobacco than not. And I think that's puts this sort of smokeless tobacco in the kind of a big factor in causing inequalities or further inequalities, because it's kind of concentrated in those populations. So let's focus a little bit on young people. And as I think for the right reasons, a lot of us are very worried about the uptake of tobacco use in young people. We know that most adults, when you ask them, when did you start using tobacco, they would refer to a time when they were young and they were adolescents. And this is the time when a lot of young people start using smokeless tobacco and other forms of tobacco. So here we have Global Youth Tobacco Survey, which is a survey which is a nationally representative survey carried out across a number of countries in the world. And this survey from 13 to 15-year-olds from schools primarily. And this survey indicates, again, very high use of smokeless tobacco in young people. And you can see the predominant countries are Maldives. But again, the most populous countries like India, Bangladesh, Nepal, you can see very high levels of smokeless tobacco use in young people. Once again, smokeless tobacco is more popular than smoking even in these countries because it's cheap, it's socially acceptable, and kids are exposed to it in a lot of festivals and a lot of social occasions. And I think adults probably are less, they don't object as much if young people are using smokeless tobacco as they would if they will be smoking cigarettes, I think, in some Southeast Asian countries. So let's focus a little bit further, and I'm going to pick up three countries, that is Bangladesh, India, and Pakistan. In fact, these three countries were part of the ASTRA consortium that I was talking about earlier. I picked up these countries because these are the three countries where most of smokeless tobacco use happens in the world. You can see from the prevalence, but also looking at the total numbers, that almost 200 million people using smokeless tobacco live in India. And at least in Bangladesh and India, they constitute the sort of largest proportion of tobacco users. So almost 3/4 of tobacco users in India are using smokeless tobacco, and 60% in Bangladesh. And Pakistan is not far behind either, by the way. 40% of tobacco users are using smokeless tobacco. And now let's look at the products a little bit in more detail. So I've already mentioned that smokeless tobacco isn't a single product, and there are a number of different products that are available, and then they change in different depending on country to country. So if you look at India, kaini, gutka, betel quid or pan with tobacco, these are some of the most common forms of tobacco, but then a lot of people use all different forms of tobacco. In Bangladesh, betel quid with pan, with tobacco, it's called zarda actually. That is the most common. But in addition, there are other products such as sada patta and gul. They're also very common. In Pakistan, the picture is slightly different. The most common one is naswar. And naswar is also very popular in Afghanistan and also in Central Asian countries. And this is, again, one of the most lethal ones. And I've got another chart where we compare different products, and you'll see that how the risk is increased with naswar. But then, of course, there are other products available in Pakistan as well. So that's what makes this whole sort of picture of smokeless tobacco extremely complex, because to understand the risks for these different products is different. And then obviously to regulate them also there are differences on how you do that. Now, smokeless tobacco, it is possible that smokeless tobacco is actually even more addictive than cigarettes. And I say that because we did a study a few years ago in Bangladesh where we measured cotinine levels among tobacco users. Now, for those of you who are familiar with the metabolism of nicotine, they would know that cotinine is a metabolite than nicotine. Nicotine actually disappears from blood very quickly, but its metabolite cotinine stays for a while. So that's why we measure cotinine. It's a proxy for nicotine levels. And because nicotine is one of the most important substances that leads to addiction, so we think that probably higher the level of nicotine or cotinine, the higher the dependency. So when we measured cotinine levels among smokeless tobacco users, we found that actually their levels were very high, and when we compare it to previous studies conducted in cigarette users, those levels were 3 times higher than cigarette users. And again, when we looked at the sort of dependency scales, we also found that the mean scores for dependency scales was also 3 times higher than what was observed in cigarette users. And I think we tried to make some parity between the two by looking at the mean amount of tobacco consumed in both groups. Now the risk. So it's just a reminder that smokeless tobacco is not really a harm reduction product when it comes to low and middle income countries. And for a very long time, I think when people used to talk about smokeless tobacco, certainly in Europe, I've been to many conferences in the UK where smokeless tobacco is almost always considered as a harm reduction product. And I used to say to myself, well, what about smokeless tobacco that's consumed in Pakistan, India, and so on? So it's definitely not a harm reduction product. It causes a lot of harm. It may not cause lung cancer or chronic lung disease, but oral cancer, you look at the relative risks here and the odds ratio. If somebody is consuming smokeless tobacco, they're at high risk of oral cancer, pharyngeal cancer, and esophageal cancer. And the odds of those with cancers having chewing tobacco history are 5 to 10 times than those without cancer. So that's quite a clear indication. We did a meta-analysis just 2 years ago where we collected a lot of history studies from India and Pakistan and other countries, and we found that the odds of cancers were quite high and associated with smokeless tobacco. And now some of the risks disaggregated on different products. So this is a systematic review. We just published it. I think it's been accepted, may not be available publicly, but I've left a reference at the end, so you may be able to see it. Here we looked at the risk of oral cancers with different smokeless tobacco products. And I'm sure you're all aware that if the odds ratio are around 1 or then it means that the odds of chewing tobacco associated with the risks are not high. But so when we look at snus, so this is Swedish snus, so this is a reference really for us, then basically it's got either no or very little risk of cancers or oral cancers, the Swedish snus. But if you look at some of the other products here, like Naswar, which I mentioned was very popular in Pakistan and also in Central Asia, Afghanistan, the risk is more than 10 times. So the odds ratio are around 14 or 15. And then again, lots of other products that are popular in Southeast Asia, like BQ is betel quid, by the way, or pan with tobacco. That's also have got a high risk. Gutka, Kaini, Zarda, all these products. Tambuk, another thing I want to mention. Tambuk is a very popular product in Sudan. And that is, again, carries a very high risk of oral cancer. So I think this just shows that the risk varies with products, and also it's also an opportunity. I think there's something that we don't talk a lot about in tobacco control is the opportunity to regulate these products so that their risk could be minimized or eliminated if these products are regulated properly. And I think the example of Sweden is there in comparison. Now, why we're worried, I mean, our group looks at these trends and we get really worried about smokeless tobacco, and we think it needs special attention, which goes back to my original remit of the talk. Here we've got, again, 3 countries. There's smokeless tobacco trends from 1990 to 2019, and they're disaggregated for both males and females. The purple line here indicates smoking trends, and the green line here indicates smokeless tobacco trends. And just by sort of quick observation is that most of the purple lines are going down. In all 3 countries, if you look at males, smoking is going down, Bangladesh, India, and Pakistan. But then there's a flat line of chewing tobacco or smokeless tobacco in all 3 countries. And that's worrying, because that means that while making a headway to reduce smoking prevalence, I think that is not having an effect on smokeless tobacco, and that's why it needs special attention. So I'm going to, I think, come to sort of middle of my talk. I'm going to turn my attention to some of the policy gaps. And what I've done here is that basically, this is a summary slide, by the way. So everything I'm going to talk about, the rest of my talk is essentially here. And this is the new knowledge that I think our group has worked in the last few years to look at some of these policy gaps. So I'll start with just give you a very brief overview, and then we'll go through some of the slides relatively quickly, leaving some time at the end for questions and answers. The first problem that we confronted was not having any definitions for smokeless tobacco. So we now developed an ontology of smokeless tobacco products across the world, and I'll explain that a little bit more. We also estimated the global disease burden, and we found that over the last 7 years, they've increased. We also estimated the economic burden of smokeless tobacco, and that was quite staggering. We analyzed data on youth, and we found that there are very significant pro-tobacco predictors for the use of smokeless tobacco in youth that needs to be addressed. And unfortunately, the anti-tobacco policies are not as strong. We found a number of policy gaps in addressing smokeless tobacco through our review work, policy review work across the globe. But the positive thing was that if these policies are implemented, then they could have a big impact in controlling smokeless tobacco. And by the way, these just not include the Framework Convention for Tobacco Control Policies, but also some of the other policies that go beyond the framework, and other countries have implemented them. They also could have an impact. But the sad reality is that policy implementation is particularly weak in case of smokeless tobacco. And therefore, we are in this situation that possibly a large number of smokeless tobacco that are consumed are potentially illicit. And we have this situation, which I explained in the previous slide, of lots of flat lines in terms of trends for smokeless tobacco. Some good news on the smokeless tobacco cessation front. There has been a dearth of smokeless tobacco cessation trials. So I'll be talking a little bit about the results of the small trial that we did. But first of all, the definitions. So smokeless products, smokeless tobacco products, I've just explained that depending on which country you are, you'll find a whole variety of products. They will differ by name, ingredients, manufacturer, and the physical forms. And up till now, there wasn't any commonly agreed nomenclature that was available. So I think a couple of my PhD students worked on this with a number of experts around the world, and they've now produced definitions for 65 smokeless tobacco products. And they all have a unique definition depending on the product type, their composition, their preparation, and the final form and the mode of use. And that creates a kind of hierarchy of classes and subclasses. This is quite useful, and now we published it on the web. So if you go to this website, which is, you can see it on this slide, you will be able to find all these definitions of these different products. And I think this is quite important because this helps us to sort of have a common vocabulary when we're talking about smokeless tobacco. And it can help to actually progress research and policy making. because now we can talk of the same language. When we saying gutka, what is gutka, then at least we know what is gutka, and we can commonly use it in research and in policy. Within the youth, we analyzed a global youth tobacco survey from 4 countries in Pakistan, India, Bangladesh, and Sri Lanka. And I mean, here in this graph, you see that smokeless tobacco is consumed even more than smoking, which I was talking about earlier. So we looked at some of the cues for smokeless tobacco use, and we found that if kids are exposed to smokeless tobacco use in public places and media, they are very likely to take up tobacco and smokeless tobacco. And also if they're offered free products, that is also was a very strong predictor. And the only strong predictor for them not taking tobacco was shopkeepers refusing to sell smokeless tobacco products to youth. That was probably the only cue that we found, which was anti-tobacco. We didn't find a huge influence of anti-tobacco campaigns or other similar activities within educational institutions. So I think from this work, we were recommending that there should be stricter enforcement of bans on advertising, promoting, and sponsoring smokeless tobacco, including social media and point of sale. And I think one of the most important things that we should do is make sure that the bans on sale to and by children should be enforced properly, because that is what's going to make the biggest difference, I think, in terms of young people taking up tobacco. The global burden of disease estimates, we have found that actually over the last 7 years, the burden has gone up. And that isn't surprising, because that's, I mean, you expect that because there's a lag period between prevalence and by the time the cancers develop. But then also the prevalence hasn't really gone down in some of the significant countries. So we're still reporting 350,000 deaths due to smokeless tobacco, and a loss of 8.5 million disability-adjusted life years. So this was published a couple of years ago. But I think the worrying thing is that this is not, this has increased by 1/3 actually. And I think we're worried that some of the gains made by reducing cigarette prevalence may be compromised if you don't address smokeless tobacco. Similar findings when we estimated the economic burden. So my colleagues, health economist, Professor Subhash Pokhrel, he developed a new model, which not only estimated the economic burden, but this model can also now be used to evaluate the policies in future. So I think this is quite a significant work. There's a publication which is under review at the moment, and we have now estimated the actual cost of smokeless tobacco, both for men and women in India, Bangladesh, and Pakistan. And these figures are there, but I'm sure there'll be a paper available very soon for you to read on Subhash's work. So I think what's important, obviously, for advocacy purposes, we can demonstrate that how much money is being spent on healthcare due to the morbidity and mortality associated with smokeless tobacco. But more importantly, I think now we are in a position to evaluate and do economic evaluation of policies by use of models such as this. Now, the last 3-4 slides, I'm going to focus on the policy gaps. A review led by my dear colleague, Professor Mehrotra, who in fact was a co-director for our Astra group. And he and his team looked at the global policies across 180 countries. And we found that very few countries actually regulate smokeless tobacco. And when it comes to contents, actually only 3% regulating. Then the taxes are, very few countries have implemented taxes on smokeless tobacco. And even those that have implemented taxes, those taxes are well below cigarettes. Same situation was for pictorial health warnings, text health warnings. Slightly better situation with text health warnings, but again, graphic pictorial health warnings. Less than a quarter had implemented graphic health warnings. And again, they were not of the same requirements as it was for cigarettes. again, very few countries ban smokeless tobacco advertisement, promotion, sponsorships. So this is, I mean, this is it really, because we are not showing sort of being even-handed when we come to smokeless tobacco. I mean, this Framework Convention on Tobacco Control is supposed to cover all forms of tobacco. It's a comprehensive framework. But when we come to smokeless tobacco, we don't even have policies, let alone implementation. We don't even have policies that are at the same level. Just comparing the three countries, India, Pakistan, Bangladesh, we have big disparities. In Pakistan, for example, there is not a single policy specifically on smokeless tobacco. And I think India has probably got the highest number of policies in this arena, and I think Bangladesh is not far behind, but they also vary in terms of their levels of implementation. So that's more work to be done, I think, in terms of having policies in place. But as I said previously, that the good news is this is again a systematic review that is led by Dr. Monica Arora and Dr. Omara Dogar. And I think they have, again, this is under review. So they have looked at the Framework Convention tobacco control policies, as well as policies that are beyond Framework Convention. And I think the good news from this review is that if you do what you're supposed to do, that is put taxes up, you're going to see a drop in smokeless tobacco use. We have estimates of price elasticity for India, Bangladesh, and Pakistan. And I think that this is something that I think is quite encouraging. There are some non-Framework Convention tobacco control policies as well, by the way. There are bans on spitting, and there are bans on smokeless tobacco sales. But I think jury's still out in terms of, we have some mixed results. So sometimes it's showing significant reduction in smokeless tobacco sales, others probably not as much. So that's something that I think we need to probably come up more evidence. But overall, taxation and a combination or range of different policies are likely to have likely to be very effective in reducing smokeless tobacco if implemented. In terms of the smokeless tobacco cessation, so I did mention that I'm going to talk a little bit about this trial that we conducted. So this trial was a small trial, but it was a multi-country trial in 3 countries, India, Pakistan, Bangladesh. And we compared nicotine replacement therapy with behavioral support, and also the combination with a very brief advice. And although the numbers are small, but the results are encouraging. And I'm very happy to report that those who received nicotine replacement therapy or behavioral support were able to quit in slightly higher numbers than those only receiving brief intervention. Although the combination of nicotine replacement behavioral support did not have high numbers of cessation, but then again, this is a small trial, so I'm not going to make too many conclusions from here, but sometimes there are interactions between, when you're combining interventions, there are sometimes interactions that can have, that can reduce the effect. So we'll be publishing the results of this trial, but possibly then conducting a larger study to confirm our results. But after a very long time, I think there hasn't been any trials in this smokeless tobacco cessation. So this would be one of the important studies to be coming out from our work in Astra. Just final couple of slides. So smokeless tobacco supply chain, we have done a lot of analysis. In fact, my colleagues, Dr. Zohaib Khan, Dr. Romana Haq, and our PhD student, Dr. Abdullah, they worked together with a number of other colleagues from India and England and Pakistan and Bangladesh, and they've done a lot of work on smokeless tobacco supply chain. And we found the obvious sort of findings were smokeless tobacco products in the variety. They're sold in different varieties and different quantities and size packs, but most of them escaping the tax net. Most of them are not complying with the national laws, let alone Framework Convention. Smokeless tobacco sale is very common amongst children, particularly in rural areas. We found that 80 to 90% kids can actually buy smokeless tobacco products if they want to in going in villages. And most of the vendors and suppliers are unaware of any policies or any potential health effects of smokeless tobacco. So clearly the implementation is extremely weak compared to others. There are a number of products that carry misleading descriptors. And even when they have pictorial health warnings, they're not really compliant. So but this could be like potentially illicit products, to be honest, because if you're not complying with the laws of the country, then those products are illegal. But then you have the whole market's full of these products being sold and used. So very weak enforcement of whatever policies we have. So I feel like I'm giving a very gloomy picture, but sometimes these things are also opportunity to make a big difference. Because if we can actually act upon some of the recommendations that are listed here, then I think we can make a big difference. I mean, product regulation, we already know the case of Sweden and how they've regulated their products. So I think some of the lessons can be learned in terms of restricting the nitrosamine levels and setting standards. All of this requires obviously policy change and also big infrastructure of labs to be able to implement and regulate these products. But we have to start somewhere. And I think some good news are coming out from India, at least, that there's some network of labs being set up. The packaging is a really interesting one because we talk about smokeless tobacco products not carrying the regular sort of the required size and specifications of graphic health warnings, but then we never standardize their packaging anyway. I mean, it's easier to do it in cigarettes because cigarettes have a standard pack, so you can put a label on, but there is no standardized packaging for smokeless tobacco. So I think if you're serious about putting a graphic health warning that is effective, then the first thing to do is to standardize packaging in smokeless tobacco. I'm glad to report that we'll be conducting some interesting research in Pakistan on standardized packaging for all forms of tobacco, including smokeless tobacco. So watch out over the next 2-3 years. We'll be doing some work in this area. I think sellers retail licensing is key here, because if you're going to regulate a market, at least we should know who's selling what and who's producing what. Then the banning on advertising, I think we've already talked about. That's quite important. Banning on enforcing bans on sales to and by children, we've talked about. Cessation services, I think, needs to be expanded to cover smokeless tobacco. Again, India is a leading example where they cover smokeless tobacco. And then tax is perhaps the most important. And I think here I'm recommending that tax should be increased frequently and greater than cigarettes, with at least a minimum floor price that should be equivalent to a 20 cigarette pack in that country. And that's when you're going to achieve parity. Here I've got a list of some publications, but I'm going to end my talk here, and very happy to answer any questions if there are any. Thank you very much.
Wow, that was fantastic. Thank you so much. You've just covered a whole big area very clearly. I'm going to remind the audience to put your questions in the Q&A box, and as you're typing, maybe I don't know, I'll take the chair's prerogative and ask a question, and I have a number, but I'll limit myself to one. Near the end, you talked about the supply chain for smokeless tobacco, and I wonder if we know much about where the tobacco comes from for the smokeless tobacco products. I know for cigarettes, there are auctions of the tobacco leaf, and certain major countries that are farming the tobacco. Does the smokeless tobacco that you've been talking about come from the same? Do the manufacturers still buy the leaf at auction in the same way with the buyers who are buying for cigarettes, or is it a bit different?
So they do come from the same sources, and most of them are growing in the country, but they tend to be the cheaper quality. So usually, what is sold in the auction is the sort of, I would put quality in inverted commas, but the top quality tobacco is picked up by the cigarette industry, but the more sort of cheap quality or cheap variety is picked up by the smokeless tobacco industry.
Great. Okay, thank you. Well, I'm going to jump into the questions, make sure we can get through a few of them. One of the questions is about the asking how you see the cultural association of smokeless tobacco with the reduction in consumption or lack thereof. I think you showed us some graphs of lack of decline, but and so one example that this participant's asking about is Naswar in Pakistan as an example. So, you know, you laid out all the policy interventions that we know are going to be effective if we use them, but what about the cultural association? Do we have to address that as well?
Yes, absolutely. I mean, I think this is we talk about this quite a lot, that we go to a wedding. I mean, I grew up in a household where smokeless tobacco was everywhere, and I remember my grandmother used to have a box with betel quid, and she was careful enough not to give us smokeless tobacco products, but they were there. So I'm very familiar with the sort of cultural associations, and you go to weddings and sometimes you see them being served. I think those need to be addressed definitely, and addressed in a kind of raising awareness through health promotion and also through community development work in local communities. But I think we mustn't forget that cigarettes were part of a culture at one point. And I think, you know, I've worked in hospitals, and when we talk to people who were around the time of world wars in Europe, and everybody was smoking cigarettes, and you know, it's just so that was part of a culture. But cultural shift happens in all sorts of ways. I mean, there's obviously policy work, but then things get unpopular and not so cool and not the social norms. So it's you know, it's, I'm going to say something very cliched, but it's multifaceted approach. I think that's we have to do in this case as well. So some of the, you know, we have to address some of the myths and misperceptions as well that are associated. We know in cigarettes, I mean, when you have flavors and colors and all sorts of things, and also in shisha, we know that when you've got fruit flavors, that kind of give a mixed message to people. So yeah, it's a multifaceted approach, but I'm very keen to actually do some work in South Asia, where we work with village leaders and village elders, and trying to then basically have a bit of a social pressure on the sellers not to sell smokeless tobacco to children. So rather than having inspectors and enforcing a sort of ban, rather than sort of more have a more sort of community development approach. And I think such approaches have been successful in other areas. I think we probably need to use those in tobacco control as well.
Right. Yeah, very important. So there were very exciting pilot or initial findings regarding smoking cessation interventions. Do you think once those findings are replicated from larger studies, that one way to roll things out might be through TB type programs? And do you have other ideas where it might be, you know, really an effective way to reach people who would be looking for cessation assistance?
Absolutely, Joanna. So I think TB is a great example, and I think you may be, or others may be aware of some of the work that my team has done in integrating tobacco cessation within TB. But I think the other thing that I would want to highlight is some work's been done by a brilliant PhD student, and she's worked in India, and she found that community health workers, ASHA workers, I think they're called in India, they could be a great source of promoting cessation. And I mean, in the UK, we have cessation advisors and so on, but I mean, I'm not sure you need that sort of specialized service in countries like India, where you have an infrastructure of community health workers. And I think they're already doing a lot of good work. I think that's what picked up my PhD student, that she talked to a lot of women and community health workers, and she found that a lot of very good work is going on in India in smokeless tobacco cessation, using behavioral support, simple counseling, encouraging women not to use it, especially during pregnancy and during childbirth, sort of childbearing age.
Great. There are a lot of compliments on your presentation in the Q&A. There are a couple of questions along the same lines. And so this theme is about tobacco industry interference. And do you feel that the relative lack of policies in the area of smokeless tobacco, particularly in comparison to cigarettes, has more to do with having less research and advocacy on smokeless tobacco products, or maybe it's or does it have to do with tobacco industry interference or something else?
Sure. I think the nature of tobacco industry is very different in smokeless tobacco. I know in India, I think the industry is more organized, smokeless tobacco industry. Also I mean, I'll give you an example of Pakistan, where there's a lot of pressure on the government not to put tax on smokeless tobacco. I talked about Naswar. So there are associations of Naswar manufacturers who would go out on the streets and do a campaign. So it's very different nature of, I think, the way this interference goes on from the industry side. And governments feel under pressure and a lot, because a lot of voters come from areas where tobacco is grown, and some of the members of parliament and ministers in the government may be tobacco growers themselves. So this, I think it's much more diffuse and much more sort of political than the kind of tobacco industry interference that we see in cigarettes, which is, by the way, is also there, as you know, very well know, in these countries. So there are these big tobacco companies that are doing a lot of interference and all the kind of things that they shouldn't be doing, and our government should not be letting them do. They do all that. But on top of that, the smokeless tobacco industry is also very organized, or getting organized. And they may not be as mega billion industry as cigarette industry, but they have got a lot of political influence, and their political influence and clout comes from the members of parliament and then politicians and ministers, where they put their pressure on. So I think some of good thinking in terms of how do you deal with that, how do you deal with that kind of political pressure, I think is important. My friend and colleague Zohaib in Peshawar, he talks a lot about working to basically on alternative livelihoods, not just for farmers and growers, but also for the sellers and some of these manufacturers who are very poor, and they've got small manufacturing units put in their top of their houses. And so I think he's done some, or his PhD student done some qualitative work and found that a lot of them would be amenable to alternatives if offered by the government.
Thank you. A question about tax. You had said that we should be taxing smokeless tobacco more than cigarettes, and just want to clarify if that's because you want to drive the price closer to parity with cigarettes, or you think saying that they should actually be more expensive than cigarettes in terms of equivalence.
Yeah, no, I think what I meant was that because our starting point is quite low, so if you're going to achieve some parity with cigarettes in terms of price, then I think that the taxes should go up quite significantly and quite frequently to achieve some parity. I think we all agree that there should be a parity on price for all forms of tobacco, so there is no substitution. So I wouldn't want smokeless tobacco users to start smoking just because smokeless tobacco is very expensive, although there is no chance of that for some time, unfortunately.
Super. So another question about why use of these products is so high in the region that you've been focusing on. Do you think some of it has to do with the perception that smokeless tobacco is less harmful than cigarettes, or just not harmful? Or do we have data on perceptions of harm for these products?
Yes, we do, actually. And I think, again, I remember a few years ago, one of my students did some survey in Pakistan, and they found that at most people were worried about the cosmetics of using smokeless tobacco and yellowness of their teeth. And I think so more people were aware of lung cancer associations than people were aware of smokeless tobacco and oral cancer. I think that has changed now. I think that's probably now there's a lot more awareness, and particularly in countries like India, there's a lot more awareness of the harms linked with smokeless tobacco. But we know that I think more people are likely, so cigarette smoking, I think anybody who could point out somebody in their family who had a heart disease or chronic lung disease or lung cancer, And it's easier to, I suppose, when you're talking as a clinician, to say, do you have anyone in your family who's died of smoking or have got a smoking-related lung disease? So I think most people would say yes. But oral cancer is, because the base is generally, it's not as common. So I think it's hard for people to relate to somebody who had oral cancer. So I think there are some sort of risk perception. I think is some work needs to be done on, how people perceive risks of these things. So it's not just that somebody is aware of risk of oral cancer and that's why they can equate it. I remember doing some work in tuberculosis and smoking, and because tuberculosis is very common in Pakistan, everybody could relate to it. And when people talk about it, oh yeah, my wife in fact passed away because of smoking and so on. So everybody has a story. I think that that's what probably it has a big impact actually on people's perceptions.
Right. And so maybe this will be our last question. We have so many great questions from participants. We're not going to be able to get them all. I know Dr. Siddiqi has a train to catch, so I think this will be the last question. And there was one is regarding regulations to avoid environmental impact of smokeless tobacco products. This participants mentioned areca nut consumption, but in addition to that, some of the products are in packages. The packages are littered. So in general, do you have any thoughts or suggestions around limiting the environmental impact of the manufacturing and consumption of the products?
Absolutely. So I think those people who are probably not very familiar with this product called pan, that a lot of people spit it as they're chewing it, they're also spitting it. And I think we used to have something called spittoons. I don't know if they are also there in the US. I know somebody mentioned that people used to use spittoons. But when people are using smokeless tobacco in public places, chewing gutka or chewing this pan product, they're spitting. And that is obviously has got environmental impact, but it's also, there's some anecdotal evidence that it might actually transmit other infections. And there was a lot of concern around COVID actually that this spitting. And I think India has probably done the most in terms of putting spitting bans. I don't know to what extent they are implemented and enforced, but that is certainly a step in the right direction. I totally agree. In fact, this morning, colleagues were talking about this at the launch of this new toolkit for implementing good practice. That one of such policies coming from an environmental perspective is to actually implement spitting bans. I'm sure there are other suggestions as well.
Great. Well, I think we're going to have to leave it there. Thank you so much. You did just an amazing job laying out sort of the big picture, the challenges that we're facing regarding smokeless tobacco and the ways forward. A lot of the questions that we didn't get to are asking more about how, interventions to help people quit. So I know that's in progress, but I'm glad that you're able to present some initial results. So thank you so much for sharing your knowledge and expertise, Dr. Siddiqi, and have a wonderful evening.
It's been a pleasure. Thank you so much. Thanks, everyone.